Here is a detailed explanation of vaginal dryness, including the pathophysiology step-by-step, treatment options, and preventive strategies. Pathophysiology, step-by-step process. Vaginal dryness primarily results from a decline in estrogen levels, although other factors can contribute. Here's a detailed breakdown. SHA1, estrogen decline. Primary trigger, menopause, postpartum period, breastfeeding, cancer treatments, e.g. chemotherapy, or medications, e.g. anti-estrogens like tamoxifen. Estrogen function, promotes blood flow to vaginal tissues, maintains epithelial thickness, elasticity, lubrication, and acidic pH. 2. Decreased vaginal blood flow. Estrogen deficiency leads to reduced vasodilation and blood circulation to the vaginal wall. Less blood flow, decreased nutrient and oxygen supply, thinner, less healthy vaginal tissues. 3. Thinning of vaginal epithelium. Vaginal epithelium becomes atrophic, thinner, drier, less elastic. The rugae folds flatten, making the vagina shorter and narrower. Decreased glycogen in epithelial cells, fewer lactobacilli, reduced lactic acid production, increased vaginal pH. 4. Decreased glandular secretions. Bartholin's glands and vaginal mucosa produce less lubrication. This leads to a dry environment, especially noticeable during sexual arousal or intercourse. 5. Increased vaginal pH. Normal vaginal pH is acidic, 3.5 to 4.5, maintaining a healthy microbiota. With estrogen decline, pH becomes more alkaline, favors pathogen growth, more risk of infections and irritation. 6. Mucosal fragility and inflammation. Lack of moisture and thinning epithelium make the vaginal lining prone to microtears and inflammation, causing discomfort. 7. Symptom manifestation. Dryness, itching, burning, painful intercourse, dyspareunia, bleeding, recurrent UTIs, urinary urgency, and emotional distress. Treatment options. Treatment depends on the severity of symptoms, cause, and patient preference. 1. Non-hormonal options. First line for mild to moderate cases or contraindications to estrogen. A. Vaginal moisturizers. Function, long-lasting hydration to vaginal tissues. Examples, Replin's KY liquid beads, used regularly, not just before intercourse. B. Lubricants. Function, temporary relief during intercourse. Types, water-based, silicone-based, or oil-based. Caution with condoms. Examples, Astroglide, KY jelly, Uberlube. C. Lifestyle modifications. Avoid scented soaps, douches, bubble baths, tight underwear. Maintain hydration, balanced diet, and regular sexual activity. Option 2. Hormonal therapy. Best for moderate to severe symptoms due to estrogen deficiency. A. Local estrogen therapy. Direct application to vaginal tissues. Minimal systemic absorption. Forms: vaginal creams, e.g. Premarin, Estrace, vaginal tablets, e.g. Vagifem, vaginal ring, e.g. Estring, used for 3 months. B. Systemic hormone replacement therapy, HRT, oral or transdermal estrogen, typically used when other menopausal symptoms are also present, not preferred if only treating vaginal dryness. C. DHEA, dihydroepiandrosterone, vaginal insert intrarosa that is converted into estrogen and androgen in vaginal tissues. D. SERM's selective estrogen receptor modulators, osbemifene, Osphena, oral CRM that acts like estrogen on vaginal tissues, improving dryness and elasticity. 3. Laser and energy-based therapies, used when other options fail or are not suitable, stimulate collagen regeneration, vascularization, and thickening of the mucosa. Examples, CO2 fractional laser, Mona Lisa Touch, ER-YAG laser, radiofrequency devices. Prevention strategies. Preventing vaginal dryness involves a proactive approach, especially in women approaching menopause or those on medications affecting hormone levels. Mano 1. Maintain hormonal balance. Regular health checkups for perimenopausal and menopausal women. Discuss hormonal changes with healthcare providers, especially before starting hormone-modifying treatments. 2. Engage in regular sexual activity. Stimulates blood flow and maintains vaginal elasticity and lubrication. Can involve penetrative sex, use of vaginal dilators, or masturbation. 3. Routine use of vaginal moisturizers, even in asymptomatic women post-menopause, helps maintain mucosal integrity and hydration. 4. Avoid irritants. No douching, perfumed products, or synthetic underwear. Choose cotton underwear, pH-balanced soaps, and avoid tight clothing. 5. Nutrition and hydration. Drink plenty of water daily. Include omega-3 fatty acids, e.g. flaxseed, fatty fish, soy isoflavones, and vitamin E for mucosal health. 6. Smoking cessation. Smoking lowers estrogen levels and contributes to vaginal atrophy. 7. Manage underlying health conditions. Conditions like diabetes and autoimmune diseases can worsen dryness. Control is essential. Conclusion. Vaginal dryness is a common, treatable condition, particularly among menopausal women. Understanding the underlying pathophysiology is crucial for effective management. A combination of non-hormonal, hormonal, and lifestyle-based approaches can help restore vaginal comfort, function, and quality of life. Early intervention and open communication with healthcare providers are key to optimal outcomes. Thank you. Have a nice day.